Hello, I'm Eric Strong, and in this installment of An Approach to Symptoms, I'll be discussing an approach to seizures. A practical diagnostic approach to seizures will look very differently depending on whether one is a neurologist, a pediatrician, or an internist. As I'm an adult hospitalist, this video will focus on new onset seizures in adults without a prior history of epilepsy. Let me start by answering the question, what is a seizure? The most authoritative definition is a transient occurrence of signs and/or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. This definition is important because it highlights that not everything that looks like a seizure actually is a seizure, which I'll talk about more when reviewing the diagnostic framework. Seizures are a complex topic for many reasons, but one of them is because of how many different seizure types exist. Here is one common consensus classification system used by neurologists. As a hospitalist, I don't find this classification system to be helpful because it's more complicated than is needed within the scope of my clinical practice. So instead, let me present a simplified classification that is sufficient for the internal medicine wards, which consists of 4 seizure types based on how the seizure starts, whether the patient retains awareness during the seizure, and whether there is associated motor activity. The first category is focal onset seizures, in which, as the name implies, only part of the brain and part of the patient's neuronal control appear affected at the beginning of the seizure. Focal onset seizures include focal aware seizures, previously known as simple partial, versus focal impaired awareness seizures, previously known as complex partial. It's important to recognize that awareness is not the same thing as responsiveness. During a focal impaired awareness seizure, the patient will be confused or unaware they are experiencing a seizure, but during the seizure, they still might be able to answer simple questions or otherwise respond to their environment. Focal onset seizures of both types may or may not have motor components, and they can progress from a focal onset to becoming more generalized. Seizures can also be of generalized onset, in which both sides of the brain are involved right from the start. In this case, the clinically most helpful next level subdivision is motor versus non-motor. Generalized motor seizures can consist of either stiffness, rhythmic contractions, or most classically both. What is referred to as a generalized tonic-clonic seizure, sometimes abbreviated GTC. In a generalized non-motor seizure, the patient may abruptly stop talking or moving. They might develop a blank stare or appear abruptly confused, on top of which may be layered autonomic or sensory changes. The classic example in this category is absence seizures, which are far more common in childhood. There is another way to approach seizure classification, which is not mutually exclusive of the former. Patients can have what's called an acute symptomatic seizure, in which there is a close temporal association to a metabolic derangement, toxic exposure, or acute brain insult, such as an acute stroke or CNS infection. In contrast, patients can also have a so-called unprovoked seizure, in which the etiology is either unknown, there is pre-existing brain injury such as a brain tumor or remote stroke, or the patient has a progressive neurodegenerative disease. This classification system helps to understand which patients are labeled as having epilepsy, which are those who have experienced 2 or more seizures from this category. In common usage in medicine, the terms epilepsy and seizure disorder are used interchangeably, with neurologists favoring the former term and pretty much everyone else seeming to favor the latter. So a patient who experiences 2 seizures while ill with meningitis does not have epilepsy or seizure disorder, nor does a person with recurrent alcohol withdrawal seizures, but a person who had a stroke a year ago and has had 2 seizures since without any other explanation does have epilepsy and a seizure disorder. 2 additional seizure terms. Status epilepticus. This is a situation in which either a seizure lasts longer than 5 minutes, or a person has multiple seizures in a row without a return to normal in between. While relatively brief seizures are not considered to be dangerous in and of themselves, aside from physical trauma that might occur during them, status epilepticus is considered to be an emergency, with the longer that the seizure or seizures continue, the greater the chance of permanent neurologic injury. While status epilepticus usually involves an image of prolonged, uncontrolled physical convulsions, there also exists an entity called non-convulsive status epilepticus, in which altered mental status is the primary manifestation. That altered mental status can consist of anything from somnolence to waxing and waning confusion mimicking delirium to psychosis mimicking a prior psychiatric condition. Non-convulsive status epilepticus is relatively uncommon, but it is also under-recognized. The last big terminology issue is probably the most confusing one, and that concerns the terms epileptic versus non-epileptic seizure. From the preceding information, you might very reasonably guess that a so-called epileptic seizure is one that occurs in a patient with epilepsy, while a non-epileptic seizure is a seizure that occurs in a patient who does not have epilepsy, such as alcohol withdrawal. And although that's occasionally used, the words are occasionally used that way, that's not typically how the field uses these words in the literature and in textbooks. In current use, an epileptic seizure is one characterized by abnormal electrical activity in the brain that can be registered by an EEG, while a non-epileptic seizure is one in which the brain's electrical activity is grossly normal. Now you might say, hey, wait a minute, I thought you said at the beginning that a seizure, by definition, is due to, quote, transient occurrence of signs and or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. So isn't this term non-epileptic seizure inherently contradictory? And yes, it is. That's why some clinicians don't use this term and instead either continue to use the older term pseudo-seizure or newer terms like functional non-epileptic attack or non-epileptic spells. I don't want to fall down the rabbit hole of which term is the most accurate or appropriate because there are surprisingly strong opinions on this issue. I'll just say that at the present time, non-epileptic seizure appears to be the most common term in the literature to describe the phenomenon of an event that outwardly appears to be a seizure, but which is not caused by grossly abnormal electrical discharge in the brain. Although generalized tonic-clonic seizures are just one type of seizure, it is the most common type encountered on the internal medicine service, so I'm going to spend a few minutes talking specifically about what one looks like because they do have a typical pattern of symptoms and signs. Before the actual seizure starts, there may be a prodrome of irritability and anxiety lasting as long as hours, followed by the aura or early ictal phase. The aura can consist of sensory phenomena such as strange sounds, tastes, or changes to vision. Déjà vu, the sense that what is currently occurring to the patient has occurred before. And the less commonly known jamais vu, which is the sense of being unfamiliar with a person or situation with which the person should be very familiar. And some patients experience fear and a sense of impending doom. The aura or early ictal phase can last seconds to minutes. Importantly, not all patients with true tonic-clonic seizures experience prodrome and or an aura. Next is the ictal phase, or the actual seizure. In the classic presentation, it starts with a tonic component in which the patient experiences a tensing of their muscles, loss of consciousness, loss of postural tone, and may let out a loud moan, sometimes referred to as an ictal cry, not to be confused with literal crying, which may or may not also be a feature of a seizure. After the tonic component comes the clonic one, which consists of rhythmic contractions and relaxations of most of the patient's major muscle groups. The patient is often incontinent of urine, plus or minus stool. There may also be foamy salivation. The ictal phase normally lasts less than 5 minutes, with 1 to 3 minutes being the most common duration. After the seizure is finished, the patient enters the post-ictal phase, which consists of somnolence, confusion, fatigue, weakness, and headaches as they slowly regain consciousness. The post-ictal phase can last as short as seconds to as long as hours, with about 10 to 20 minutes being the most common. However, the post-ictal phase can seem to last for days in elderly patients and in those with neurodegenerative disease. A complete lack of post-ictal phase in which a patient immediately transitions from appearing to actively seize to being fully conscious and responsive is evidence that the event may not have been a true epileptic seizure. So now let's talk diagnostic framework. What are the individual etiologies of seizure in adults? There are many, which can be classified into systemic versus CNS versus seizure mimics. I'll start with the systemic causes. They can be subdivided into metabolic versus toxin and medication. Under metabolic are hypo and hypernatremia, hypocalcemia, hypophosphatemia, hypomagnesemia, hypoglycemia, hypoxia, and heat stroke. There is also renal failure and hepatic encephalopathy from liver failure. A brief word about these last two causes. They are frequently included on lists of seizure etiologies and are discussed in case reports. However, I've seen hundreds of patients with kidney or liver failure, and I've never personally seen one who had suffered a seizure due to either. I'm not saying it doesn't happen, but rather that in my experience, it's rare enough that I would never attribute a seizure to either kidney or liver failure without first thoroughly investigating other possibilities. In the toxin and med category, there is acute drug intoxication with stimulants such as amphetamines and cocaine, drug withdrawal from alcohol and benzodiazepines. There are a long list of medications that can trigger seizures, of which the most commonly implicated and or discussed are antidepressants, tramadol, diphenhydramine or Benadryl, and the anti-tuberculosis medication isoniazid. Seizures are also one manifestation of severe serotonin syndrome, which is triggered by serotonergic compounds such as SSRIs, SNRIs, dextromethorphan, which is found in many over-the-counter cold medications, amphetamines, and ecstasy. Moving from the internist domain of systemic etiologies, I'll next discuss the neurologist and neurosurgeon's domain of central nervous system etiologies. These can be subdivided into structural versus infectious versus other. Other structural etiologies are tumors, both primary CNS tumors and other cancers that metastasize to the brain, various forms of intracranial hemorrhage, ischemic strokes, which can cause seizures both in the acute phase immediately after the stroke, or can lead to a chronic seizure disorder many months or even years later, vascular malformations, and head trauma. Infectious etiologies include encephalitis, which in common usage implies a probable viral etiology such as HSV, unless otherwise specified, meningitis, which can be viral, bacterial, or fungal, a disease called neurocysticercosis, which is caused by a parasitic infection with a pork tapeworm. It is relatively uncommon in the US and Europe, but is a significant cause of seizures in Latin America, Sub-Saharan Africa, India, and China, tuberculosis, cerebral malaria, and a brain abscess. Etiologies which fall into the other category include primary epilepsy syndromes, a discussion of which could be an entire video of its own. Although it's not a classic manifestation for most patients, neurodegenerative diseases can also increase the risk of seizures, including Alzheimer's disease. And last in this category are the overlapping phenomena of paraneoplastic and autoimmune encephalitis, in which the body produces antibodies that attack specific targets in the brain. Finally, are the seizure mimics. These are conditions that can look like seizures both to laypersons and experienced clinicians, but which are not caused by true seizure activity in the brain. Most prominent in this category is a condition which I already briefly introduced, psychogenic non-epileptic seizures, or PNES. PNES is a condition in which a patient has involuntary experiences that look either like classic seizures or syncope, but are not associated with seizure activity as recorded by EEG. They are believed to have a predominantly psychological origin, but again, they are involuntary. Adding to the diagnostic confusion, epileptic seizures and PNES can coexist in the same patient. Other seizure mimics include syncope, especially syncope that is accompanied by mild clonic jerks. A transient ischemic attack could potentially look like a seizure. Some migraine headaches are accompanied by sensory auras and can thus mimic non-motor seizures, though unusually severe migraines can also rarely trigger true seizures as well. And last, the tremors that a person can experience during alcohol withdrawal can be mislabeled as a seizure by the patient or layperson observers. Although there is much variability depending on the population one is seeing, the most common causes of a first generalized tonic-clonic seizure in U.S. adults include hypoglycemia, alcohol withdrawal, tumors, ischemic strokes, encephalitis, and meningitis. Now that we've gone through that extensive list of potential etiologies of a seizure, how do we evaluate a specific patient's seizure to determine which specific etiology was its cause? It starts with the characteristics of the seizure. What was the nature of any involuntary movements? Was consciousness maintained during the event? Did the patient experience bladder or bowel incontinence? Were there pre- and post-ictal symptoms? If so, what were they and how long did they last? Were there potential triggers to the seizure, such as sleep deprivation, stress, or alcohol or drug use? Were there any associated symptoms suggesting a CNS infection, such as fever, headache, neck pain, or confusion preceding the seizures? Weight loss might suggest an occult cancer. Is the patient immunocompromised and at risk of opportunistic CNS infections, such as fungal meningitis? Does the patient have a history of prior stroke, cancer that could suggest metastasis or paraneoplastic encephalitis, disorder of hemostasis that could predispose them to either an ischemic stroke or intracranial hemorrhage, or an endocrine disease that could predispose them to hypoglycemia or electrolyte abnormalities? What's the patient's medication history? For example, serotonergic meds, particularly tramadol, and antidepressants. What's their substance use history? And their travel and exposure history. For example, visiting or living in a country where cysticercosis, malaria, or tuberculosis are endemic. Moving to the exam, in addition to the vitals, you obviously should perform a thorough neuro exam, looking for focal findings that could suggest an intracranial mass lesion or stroke. Examination of the reflexes could also uncover findings consistent with electrolyte disorders or serotonin syndrome. There are a collection of findings called meningeal signs that are most typically thought of as signs of meningitis. The most helpful of these is neck stiffness or pain with either passive or active range of motion of the neck, which should be done very gently. In the context of the clinical exam, when present, this is often referred to as nuchal rigidity. A sign that's used in patients with concurrent headache is called the jolt accentuation test, in which the headache is momentarily worsened in response to actively turning the head back and forth at a rate of 2 to 3 times per second. Two other meningeal signs that are often discussed in textbooks and lectures, but in my experience are not commonly relied upon in adults, are the Kerning sign and Brudzinski sign, both of which look for pain and or involuntary movement in response to stretching of the meninges. Examination of the oral cavity could reveal tongue bites if the occurrence of a seizure is uncertain from history. If the history suggests the possibility of an undiagnosed cancer, such as heavy smoking, weight loss, or failure to thrive, then a much more complete exam is obviously warranted. And particularly for patients who experienced a generalized seizure, it's necessary to examine their entire body for evidence of traumatic injury. And then, what are the key tests? First and foremost is serum glucose, given how acutely dangerous severe hypoglycemia can be, and how quick and easy it is to check. This should be checked before even performing a history or exam. It's the equivalent of checking an ECG in a patient presenting with acute chest pain. Other tests include a CBC, looking primarily for leukocytosis that could suggest an infection, a complete metabolic panel, looking for electrolyte abnormalities, kidney or liver dysfunction, a urine tox screen and ethanol level. Virtually every patient with new onset seizures requires neural imaging. While there may be some uncommon situations and locations in which MRI is the preferred initial imaging modality for evaluation of a new onset seizure, CT is usually the initial test of choice, with proceeding later to an MRI only if the diagnosis remains uncertain. A lumbar puncture, or LP, may be used to sample the CSF if infection or subarachnoid hemorrhage are still being considered. but only after imaging has first ruled out a mass lesion. One test not listed that you might wonder about because you've heard about is prolactin. Textbooks and review books often discuss how prolactin is elevated after a seizure, so it would seem likely to be helpful in cases in which it's not certain if a patient did in fact experience an epileptic seizure. However, prolactin is not practical since it needs to be drawn within 10 to 20 minutes, and it needs to be compared to a baseline level, which is almost never known. Another test that I don't think is helpful here is lactate. Lactate is often elevated after a generalized tonic-clonic seizure just from the seizure itself and has no diagnostic utility in differentiating infectious from non-infectious etiologies. So how do we put all this information together into a practical flowchart? When dealing with a possible new onset seizure, the first step is to check the blood glucose. After that, the next step is determining whether an epileptic seizure did in fact occur. Most of that decision will be based on the history. For example, was there stereotypical motor activity, an aura or a post-ictal period of confusion? Was there a loss of consciousness for an episode that sounded like a generalized seizure? Was there incontinence? Did the patient experience physical trauma? Are they on a high-risk medication? And do they have a history of heavy alcohol use? In addition to those historical questions, perform a thorough neuro exam and check a metabolic panel that includes calcium. If all that information establishes both that a seizure occurred and the general etiology, great, go ahead and treat, and if necessary, further work up that etiology. For example, if the patient has hypocalcemia, you of course need to determine why they are hypocalcemic. In some cases, the history, neuro exam, and an unremarkable metabolic panel may all clearly point away from an epileptic seizure. In this case, explore seizure mimics, including PNES. In other cases, though, this first pass workup will either clearly or possibly be consistent with a seizure, but the etiology will not be immediately certain. In this case, proceed with a urine tox screen, ethanol level, and a head CT. If the etiology is established from that, great, go ahead and treat, plus or minus additional workup. If the etiology is not established, and CNS infection and or a subarachnoid hemorrhage have not been ruled out, and a space-occupying CNS lesion is not seen on the CT, proceed with a lumbar puncture. If the LP is consistent with either infection or hemorrhage, go ahead and treat. On the other hand, if either the LP is not diagnostic or was felt to be unnecessary, get a brain MRI and an EEG. If even after all that, the etiology is still not established, do an LP if it wasn't done already, reconsider seizure mimics, and consider rare seizure causes which may require more specialized testing. The key takeaway points for this video. Seizures can be classified based on symptoms, such as focal versus generalized, intact versus impaired awareness, and motor versus non-motor. And they can be classified based on trigger, such as so-called symptomatic versus unprovoked. Overall, common causes of a first seizure in an adult in the US include hypoglycemia, alcohol withdrawal, tumors, strokes, and CNS infections. Following a seizure, the most time-sensitive action is to check the blood glucose. A history, neuro exam, complete metabolic panel, and imaging are sufficient to diagnose most causes of seizure. And last, a lumbar puncture may also be necessary if CNS infection or subarachnoid hemorrhage are under consideration.